Hello everyone. Yes, so I will be going through some of the protocols and also through some of the new changes as well as what is existent in terms of journey of a patient through preconceptual, early pregnancy, and then during her pregnancy, what we expect. Thank you. So feel free to stop me, and I was hoping to make this a bit interactive, and then we can go over anything that if you feel needs more attention. So basically, early pregnancy, life's always a rich and steady time when you're waiting for something to happen or hatch. Most of the times this is true. As far as early pregnancy is concerned, I like to think of it as a puzzle. So what the patient, the sort of symptoms a patient has makes one piece of the puzzle. You know, is she bleeding? Is she having any pain? Is she otherwise asymptomatic? The other piece of the puzzle obviously is her examination findings. And so abdominal findings, you know, cervical findings, hemodynamic stability. What is her beta-HCG doing? And I'll talk about what context we do beta-HCG's quantitatives in, but obviously to know that she's pregnant, we would have done a single qualitative urine pregnancy test mostly at the beginning. And of course, if we're unsure of where we're going with an early pregnancy, particularly if there's been pain and bleeding, we would like to do an ultrasound to see what's going on, help give us another piece of the puzzle. So basically, the two questions we're trying to answer at the very beginning in a pregnant lady with symptoms is, where is the location of this pregnancy? Is it intrauterine or is it extrauterine? Is that normal or is that an abnormal pregnancy? The other thing, obviously, is that is this a viable pregnancy, or is this, unfortunately, a pregnancy that is not going to survive? So these are our two questions. I've mentioned that we will go through, you know, those are the sort of history that we are interested in. So as far as the pregnancy test, the urine pregnancy test is concerned, it has an alpha and a beta unit. The alpha unit is similar to thyroid stimulating hormone. And therefore, as a sidetrack, basically because when HCG rises and it's similar to TSH, it has some thyrotropic properties. So it acts on the thyroid to release thyroid hormone, which is why some women can be hyperthyroid in early pregnancy. The beta subunit, of course, is specific for HCG. And that's the part that we test for in the urine test. And basically, the urine pregnancy test is positive from very low serum levels. So before the lady has missed her period, if she's pregnant with a monoclonal normal urine pregnancy test, she should test positive, okay? And that's on the day 23 of her cycle. The other concept to appreciate is around discriminatory zone. So roughly at around beta-HCG levels of 1,500, we should start seeing a sac or a intrauterine component of that pregnancy. At levels lower than that, whether it's a normal pregnancy, whether it's intrauterine or not, you're not likely to see very much, because we're really talking about a few molecules. We're not talking about a bigger substance of tissue at that point. So just before we actually go into more of the later pregnancy journey, the only other concept I wanted to touch on was that if you have an intrauterine pregnancy that is less than 25 millimeters in diameter, but let's say, for example, patient might have some bleeding or may not, for some reason you've done an ultrasound, then that is called an intrauterine pregnancy of uncertain viability. So at least we are confident that that's in the uterus, but we don't know whether it's going to progress as normal or it's not going to. So that's uncertain viability, and only time. This is a real game of patience, and I think we've got to prepare women for that, to say, look, unfortunately, we don't have a crystal ball. It's only time, a week, 10 days, 2 weeks, that we'll be able to know the progression of this particular pregnancy. So that previously, a couple of years ago, from prior to 2011, we used to use 20 millimeters. But now we say if it's 25 millimeters, the gestational sac, and there's no yolk sac or there's no fetus, then unfortunately that's a non-viable pregnancy. So that's one definition of it. You've got the sac, but nothing in it, and that sac is at or more than 25 millimeters. The other situation where we can confidently declare non-viability is when there is a fetus, but the crown rump length is 7 millimeters or more, and we don't see any cardiac activity. And this is obviously with a transvaginal scan. We're not talking about a transabdominal scan. With a TV scan, if we see a baby that's that 7 millimeters but no cardiac activity, we can then confidently say that this is a non-viable pregnancy. I'm not going to go into too much detail as to what we do after that, because I think that's a whole talk in itself. And we then will go on the journey to a preconceptual care. So we know that it's very ideal, it's an ideal situation for a patient or a couple to actually seek preconceptual care. A number, up to half of pregnancies are unplanned, so unfortunately they sort of miss the boat when it comes to that. But it has been shown to improve pregnancy-related both mother and perinatal outcomes for baby. And this is an old concept, well from the 1800s, where the conduct of the mother, even before her marriage, as well as during her pregnancy, was, people thought that, look, this is having an impact on the well-being of the child. So let's go around the room to make it a bit interactive. So what do you do when someone comes for preconceptual counseling? What are the concepts that you're trying to cover? May I start with you? Yes.
Alcohol, tobacco.
Excellent. So we want to know whether she's been using any drugs, alcohol, or tobacco, and that's a great opportunity to discourage her and see if we can, get her to stop using or minimize using those substances.
You want to find out what she's immune to and what she wasn't, because if she's thinking of trying to fall pregnant, you want to make sure she's immune to measles or chickenpox.
So excellent. So we want to establish what her two common conditions are, particularly the conditions that we actually have vaccinations for. So our aim is that every woman who is going to embark on a pregnancy does that in a position of strength. So for example, rubella, because we can then immunize her. We would like to know whether she's been immune to varicella, like you rightly said, and we want to establish those facts.
I'd like to get the pap smears up to date.
Excellent. So we want to know whether they've been normal or abnormal, because obviously if there's any symptoms of abnormal bleeding or there have been any abnormality in the pap smears, we'd rather get that sorted and treated rather than saying, well, now we've got 9 months ahead, we're not sure, that sort of situation, to avoid that situation. That's an excellent suggestion. Yes.
Just sort of past pregnancy histories or miscarriages, and then looking at medical histories that might.
Yes, so excellent. So like epilepsy or any cardiac disease. Thyroid, excellent, very, very good example. So we obviously want to optimize those medical conditions, but we also want her to have an informed consent. So this lady may change her mind if she understands the impact of the pregnancy on the pathology that she may have, or the progression of the disease that might occur because of the pregnancy. So there are two factors. It's a two-sided coin, because her disease obviously might get worse or better with the pregnancy, or the other way around. The fact that she has lupus or the fact that she has renal disease may impact on the well-being of the baby, like intrauterine growth restriction or a higher tendency to a miscarriage, or things that she may not feel that she's happy to take that degree of risk, especially if it involves her personal well-being, like in certain cardiac conditions, etc. Yes?
Later I did a chat about supplements.
Okay, so what did you have in mind? What supplements?
Folic acid,
Excellent.
500 micrograms a day.
Perfect.
Iodine, 150 micrograms a day.
Perfect. Okay, so those are the two recommended supplements nationally, so NHMRC. And one thing I was going to go into later on in the talk was around that we now have national guidelines, and I've requested Brooke and to help us put the links on for each one of you. This is module 1. And we've got 2 modules currently out. So the plan from NHMRC nationally is to actually cover the journey of the patient from preconceptually all the way to postpartum care. So we haven't gotten that far yet. We've gotten the early pregnancy one and the 2nd and 3rd trimester one. So the aim of these documents is to standardize care, because state health protocols are so different sometimes, and we want a minimum standard. And obviously, at the end of the day, care is meant to be very patient-focused, and we may find that we've got to tweak a number of those protocols or those tests or things to meet our own patients' needs. But in general, it helps standardize care for all of us. Okay, that was a very good suggestion. Anything else preconceptually? Okay. Yes, and that's very good. And that leads on to genetic counseling if she needs any of that, again, to help her make a decision, or for her to perhaps, look at certain assisted reproductive support in terms of if we're looking at an X-linked or a particular type of a condition. But I'll leave that. Colin might glare at me for taking his topic. So anyway, I think you guys have already covered majority of what I had on the list. And some facts that we all know in the room that there can be a significant background of abuse. There is that potential for diabetes, asthma, hypertension, anemia. These are all things that we can optimize or look at least establishing a baseline for. So if we know what our patient's baseline is, we then can monitor any deterioration or improvement from that point onwards. And the UK have a good system of analyzing very tragic maternal mortalities, where they do that every 3 or 4 years and look at a cluster of obviously the handful of maternal deaths that have occurred. And what they've found in more than half of the mortality cases, there was some underlying either neurological condition, cardiac condition, psychiatric, or obesity. There certainly was some either pre-existing or some condition that came into play in early pregnancy that may have potentially contributed to that outcome. So we've talked about folate fortification. We know that now it's become mandatory with wheat since 2009, and that neural tube defects are somewhere in the range of about 1.5 in 1,000. So this is not a large number of babies that have them, but obviously it's something that we can do something constructive about. And therein is the need for the folic acid 1 month prior to someone, at least 1 month prior to falling pregnant. And because obviously patients don't know when they're going to be successful, they should be on the folic acid if they're trying. And then 12 weeks into the pregnancy. So who needs more folate? And you rightly said 0.5 or 500 micrograms. There's a group of women that need 5 milligram. Any thoughts around? Yep.
Yes, someone with a history of Down syndrome in the family.
So if they've had a neural tube defect or a prior either anencephaly or spina bifida, yes, very good answer. That is the person that needs a 5 milligram supplement because they're obviously at a higher risk of having it again. Anyone else?
Patient who has a seizure disorder on medication.
Excellent. So anti-epilepsy, very good for the folate. Anyone else? Any other thoughts? Who might be incubating more? 2 babies? Multiple pregnancy, exactly. So this is our group of women who need it, even if they have a strong family history of a neural tube defect, if they've had a previous pregnancy with, like you rightly said, a previous pregnancy, but with a NTD. The anti-epileptics, and also women with a BMI over 30, as well as multiple pregnancy. So then I'm sure you're far better than me regarding the issue with influenza and pregnancy. What are your experiences with encouraging women to have vaccination in pregnancy? Anyone?
40% take it, 60% still don't want it.
And do you encourage it?
Somebody said you're better off having a flu so you don't suffer in the second trimester. Earlier you have better it is. And it's free of charge, so you do try to push.
So good. So you're certainly trying to minimize the barriers and encourage her to have it. Yes? Were you going to offer? Exactly what? Yep.
I think women tend to be more comfortable now, but I think the doctors who are still uncomfortable are giving it in early pregnancy.
I'm very glad you've brought that up because I was going to say, is there any discomfort in the room regarding saying confidently that, we can give this at any stage in pregnancy, or do you feel that obviously at the end of the day it's her decision and we have to respect that, but it's also in how we present the information to the patient. So basically, as we know, it's a tetravalent vaccine, and every year it changes to meet the needs of what the infectious diseases group feel is the best suited for that particular year. And certainly your risk of hospitalization, so if a patient gets influenza, is actually 5-fold by 3rd trimester. So it's such a significantly increased risk that, and I think women don't often appreciate that, because at the end of the day, most of the flu that they've been accustomed to or had has, self-resolved with, maybe some malaise, some minimal pyrexia, but they don't quite appreciate that this is something that could take you to ICU, that could actually lead to an earlier delivery, that could have significant impact. And again, there's something that we can do something about. So there's so many conditions that actually we can do nothing about, but this is different. So, and the risks, why they're more likely in pregnancy to deteriorate is because obviously it's an immunocompromised condition. It is a condition where there's reduced tidal volume, so they're not maximizing their lung function, and there is a reduced cardiac reserve underlying. So when it then gets exposed to influenza, it's actually much worse than otherwise. And then women who are hospitalized with flu and are pregnant then will have longer hospital stays, and they have a higher chance, obviously, of a preterm delivery and of a cesarean section. Because from our end, if we feel, look, she's really unwell, then we would want to facilitate the delivery after stabilizing her. And we may not feel that she's suitable for labor. And so things that maybe potentially there were lost opportunities that if she had had the vaccination may not have had it that nasty. So the other thing is around obviously progression to pneumonia and venous thromboembolic events and renal failure. We're talking about very unwell patients there. So we use inactivated flu vaccine, and that's one thing I think that's good and important to emphasize to the patient, and that there have been significant studies with thousands of women which have not shown any definite complication for the patient or the fetus from a purely pregnancy point of view. I'm not talking about, redness or the flu-like symptoms that one might have, or minimal pyrexia, etc., but specific fetal symptoms. So, and then obviously there's a reduction in febrile, and there's the benefit of it is the passive immunity for the infant as well. And the facts are that we need only between 6 and 20 women to be vaccinated to prevent one neonatal, or actually under 6-month infant hospitalization. So the numbers are not very large. We do not need to treat hundreds of women or to manage hundreds of women before we see a benefit. And also from the IUGR or SGA point of view, again, between 6 and 10 mothers need to be vaccinated. So there is a RANSCOG, which is the ONG College guideline on influenza vaccination for pregnant women. So I think all the major colleges are really trying to come out and endorse it and try to encourage us to, encourage it. So who's familiar with Mother's Safe? Okay, excellent. Most people, that's great. So Mother's Safe is an organization that's run out of Royal Hospital for Women. And it's both a helpline as well as the actual clinic, and they triage themselves. It's led by a pediatrician, but it's a combination of midwifery, obstetric, and pediatric workforce. And what they do is they provide telephone support for clinicians if we have any uncertainty, and this is a really wide range of questions that they answer. So from things like, patients will come and ask, can I use a hair dye, or can I use, or I got exposed to this tick, or like some random things that are not your typical everyday questions. And that I often encourage, if I'm not sure of the answer, I often encourage, I'll ring them myself, or I'll encourage the patient to ring that number and get information. And if they think that's a significant exposure, they then invite the patient in for face-to-face, or if it's someone with undue anxiety, so then they triage out the resources that way. So they've got an influenza vaccination sheet. They've got a number of sheets that I find quite helpful. And just like you rightly say, the uptake is gradually increasing. I think people are certainly getting their heads around it as a more consistent part of pregnancy, and it is free for pregnant women. Okay, so the next concept I wanted to talk about was exercise in pregnancy. And so I think this is very self-explanatory. Really, if someone's planning pregnancy, usually what we aim for is a moderate intensity, and a number of women are already in that routine, and we encourage them to continue roughly about 30 minutes of a moderate intensity activity daily, or 5 to 7 times. That does sound like a lot of, I'm always trying to get my exercise routine. Sorry. But yeah, but ideally that's a good routine to be in. And again, if she's already in that, then you encourage her to say, look, there's no need to stop just because you're pregnant. It's actually healthy for your pregnancy. And this is, we're assuming a low risk pregnancy. We're not assuming, you know, any significant risk or the exceptional patient that might have something that would make us revisit that advice. Obviously, the activities that we worry about are either the high impact ones or the ones where your core body temperature rises significantly, or where, you know, there's sudden, like scuba diving, where there's, what do they call that word, where you decompression. Thank you. So those are the ones we actually say really you should avoid during pregnancy, because it could have a negative impact on you or the pregnancy itself. It could be an abruption if you've suddenly, and sometimes even the racket sports that are done with a very significant force can actually have a transmitted effect on the placenta and abruption. So again, it's just that sensible advice around being sensible and not overdoing it, and avoiding things that have risk of falling, like obviously, you know, martial arts, and, you know, and again, I think these things, if they're done in a moderate manner or in a mild manner, that's still fine. But the worry is that, you know, if they're in a group, and then one can get quite carried away and not realize that rhythm is actually too fast. So our college have a series of materials. The only thing with these is that they are bought. So they roughly, I think, work out at about, I might be wrong, but somewhere around just under, Jody, would it be $1 or, because something around that mark. So they are, and there's, if you buy them in bulk, which is what we do at the hospital, there's certainly some cost saving there. But why I like these is that they have a little part at the bottom where you can take the sticker off and put in the patient's notes. And obviously you can always write that you've given a written material, but it's just a little added level of confirmation, which probably not in this context, but certainly when we're going for gynecological procedures and major procedures, we find it quite comforting to put the stickers in the notes to, you know, substantiate that we've given written material. So travel in pregnancy, again, there is a pamphlet there that we tend to give. You're probably, again, much better than me at advising regarding which vaccinations are suitable for which parts of the world. And so that's one thing that we need to go through. Malaria, if they're going to malaria endemic areas, whether it's falciparum or Vivax, which particular anti-malarial they'll be on, whether there's a need for a safety, for a mosquito net, insecticide, reinforced. So those are certainly the specific things that we need to go. But from a purely pregnancy point of view, the things that we like to cover with the patient are long haul flights do increase your risk of venous thromboembolism. So again, things, if you are going, try and keep well hydrated, try and mobilize as much as is practically possible. You can even exercise your legs within the aisle or within the seat passively. There's potential to use stockings, but they have to be used well so that they're not actually causing a problem. As far as, even though pregnancy is a hypercoagulable state, technically the jury is still out as to whether it adds on to that risk of a venous thromboembolism. So both this and the NICE guidelines say that it's uncertain. And again, we've got to say that, look, there may be a higher risk because you're pregnant to have a clot, a DVT or a PE. The other thing that's really important to go through is the medical insurance bit. And I make sure that I go into concepts like, so will you be covered if you have a medical issue regarding your pregnancy? And specifically, please ask, have you considered what would happen to your baby in terms of, because we've had situations where women have gone overseas, not really, they've sort of bought some no-frills type of insurance that's covered them, but then when they've actually gone into labor, it's not covered the baby. And we know that when someone goes into preterm labor, that's when, I'm not even talking about the emotional or how difficult that situation would be from a purely medical point of view, but from a cost point of view as well, that meter can sometimes be running, and depending on where they're visiting and whether they're, relationships in terms of at a national level to cover that cost. So that situation of the unborn baby and the cost, I think, is really important to explore. Again, I think we've covered most of this. And if they're traveling, the 3-point placement of the seat belt, so above the belt and below the belt, and not over, sorry, above the bump and below the bump, not over the bump. So that's the correct encourage that we should encourage them to do. Then BMI and healthy eating. I'm sure that you're all familiar with the Australian Guide to Healthy Eating, the 5 groups. And basically this is just, I'm just stating that what you already well know. And that 1 in 4 Australian children are obese or overweight. And these are obviously the list of issues that they can contribute to in pregnancy, and particularly in the intrapartum context and postpartum context, where there's a higher chance of having a shoulder dystocia, needing an instrumental delivery, stillbirth, placental abruption. But purely from a shared care point of view, the antenatal journey side of things is that it can make it really hard to have the fundal height and know whether that fundal height is truly reflective of what the baby size is. So therein is in these situations that most people would order another ultrasound in 3rd trimester to try and see if there's any concern regarding large for gestational age. Here you go. Yeah, that's all right. So again, so the nutrition around the Australian Guide to Healthy Eating again gives us some minimum standards that we'd like everybody to try and achieve. 3 to 4 serves of dairy food, which is around covering about 1,000 milligram of calcium per day, is what we're hoping that women who are either pregnant or breastfeeding, that they're achieving. And 1 serve, the good thing about that document is that it actually breaks it down to, it's not just, you know, like one gram doesn't really tell us very much to tell our patient, look, what is it, or how would you actually attain that amount? So the good thing is that they've actually quantified various serves, and that makes it easier for us to say, look, if you had 1 of these or 1 of these and plus 2 of that, that would make up what your minimum needs are during pregnancy. And again, there's a need for health. And there is a website that one can refer patients to if needed. Patients will often ask, what shouldn't I eat? I think they're more likely to ask, what shouldn't I eat, rather than what should I eat? And so, again, soft cheeses. So we're worried about listeria. We're also trying to cover salmonella and alcohol. So raw eggs might contain salmonella. Again, listeria is pâtés and you know, undercooked food is more likely to lead to that. And certain, I'm sorry, I've already gone through Mother's Safe. I'll just skip that. So smoking related advice, we know that this is a really good opportunity in pregnancy to encourage women to stop smoking or at least minimize it. And currently about 13% of women, once they look at national data, smoke. And obviously, part of that is trying to establish, because we know that many times patients don't feel comfortable admitting to the fact that they may be doing that. And so to try and create an environment where we can ask, but ask in a very sensitive way, so she's comfortable to share what her current situation is. And again, provide advice and quit line and suggestions on how access to behavioral or counseling or drug and alcohol representation. Nicotine replacement therapy, again, there's no conclusive data to say that it's better to put women on that. And generally, we're talking about heavy smokers in this context. So, but again, you know, it is something that we say to women, look, there's limited data. It's not unsafe, but there isn't data to say that it's definitely the best thing to do. But if it is going to be used, intermittent formulations like gums and lozenges are preferable to nicotine patches. And the British literature suggests that if women are going to use patches, then encourage them to take it off at night. Again, you're just trying to minimize trying to get that perfect balance to get enough replacement for her to stop, but not overdo it if you can avoid it.
Is nicotine itself dangerous?
So look, I think it's a combination of the nicotine, the tar inhalation, and the carbon monoxide, but it is all 3 of them are implicated. So it is certainly one of the causative organisms.
Nicotine component itself.
Yes, it is. Yes, it is. I mean, that's one of the actual nicotine in the cigarette. But then what we feel is that this is actually a smaller amount that we're giving. So therefore, we're potentially avoiding the larger amount should have been exposed to. But it is one of the implicated, which is why they're not confidently coming out to say, yes, use it. So I guess the most optimistic situation is to try and get them to stop. And it is a time that I think women are generally keen to try and explore reducing or stopping. Yes, Caroline?
What about something like Champix in pregnancy? Is that something you ever consider?
Champix?
Yeah.
I don't know what they
so
are.
is it a medication that you give someone to help them stop smoking?
Okay, so is what exactly? I'm just sorry, I just haven't prescribed it before.
No, from the
Has anybody else got any experience? I can certainly read up on it and get back to you.
I'll let her say.
Yes. Thank you. Thank you for thinking about that before me. Caroline, I'll get back to you about that one. I honestly have not prescribed it.
anyone using it, I was just wondering what your thoughts were. But
No, I apologize. Because I haven't prescribed it and I don't know the information around it, I'll get back to you. Yep. So the ratio is almost 4 times number of women are likely to stop during pregnancy if supported, as opposed to non-pregnant women. But the downside is that almost 2/3 of them, once they've had the baby, are going to go back to smoking. So now whether some of the studies are showing that if their partners smoke, they're more likely to go back. But again, it may be that the psychology is around, look, I'll not harm the baby, but then once they've delivered, they think, oh, well, you know, now it's just me. Or it may be that there is a contribution from, you know, the fact that it's stressful, they're not sleeping, they're looking after a young baby. There are many reasons why women go back. But unfortunately, I think from a hospital point of view, we worry that we try to support them during their antenatal journey, but we don't often have that advantage that I think shared care GPs have, that privilege that you can actually continue to share that part of their postpartum journey and try and minimize the women that go back into that situation. So again, alcohol, are you aware of the new revised guidelines around alcohol and pregnancy? What do they say? Yes. So there's no, they're just saying effectively, there's no minimum safe level that they can confidently come out and say, look, if you have this many drinks or if you have less than this many drinks, it's fine. So therefore, they've just said, if someone's trying to fall pregnant or is breastfeeding, just avoid it. So, which is, you know, sometimes not very easy to do. And do we agree with that? And again, so, you know, the issues there are around the fetal alcohol syndrome, and it's very difficult to diagnose. It's often not something that we can pick up on ultrasound. It can be very fine, the presentation, and it's usually a pediatric pickup later on that, you know, then links it. And there's underreporting of alcohol use. So again, the need for us to specifically ask rather than wait for the patient to volunteer, because that may not happen. We're quite familiar with what some of the more standard patterns are, particularly around the smooth philtrum and the upper lip and palpebral fissures in very classic cases. There's a baby with the alcohol effects. And of course, developmental delay and intellectual difficulties and learning difficulties, again, things that sometimes may come up later, and hand-eye coordination. So our current guidelines, as we said, is basically to avoid it. And are you familiar with the Women Want to Know campaign? No. Okay, so this is a campaign which has been, it's a joint venture. It's from our ONG college, as well as there's an institution called FAIR, which is Foundation of Alcohol, I may not get that right, but alcohol research, I think, and education, but it's an alcohol-related organization. And basically 2 or 3 large group of, you know, relevant bodies have come up with this campaign, and this campaign has two parts. It has a part that is to try and make resources available for women, but there's a clinician part, and the clinicians they cover are midwives, are medical practitioners, GPs, and specialists. So there are online videos, and basically just the underpinning momentum is to say that, look, they do want to know, women want to know, and how we can approach it. So there are a number of videos there saying, you know, patients, how to encourage them to volunteer or to how to have that conversation. And it's just to help guide us to be able to approach that issue with patients better. And it's a national public health initiative. And we can put that as one of the links later, you know, on our platform. Yep. Sorry, how am I going for time? Just stop me if I've...
It's nearly 15 minutes.
Okay, all right, all right. Yes, that will work. Yep. So yeah, I was just guessing. I almost got it right, I think. Yeah. And so it attracts CPD points as well. And there's the Audit C alcohol use disorders identification tool. So I've already mentioned about the clinical practice guidelines. Again, I find that this is very helpful. I do a lot of work for our college because I'm very passionate about GPs and the interface with women's health. And so that's just a little bit of data, how more GPs are doing the diplomas. And we're delighted to have increased numbers in Certificate of Women's Health. This is actually two years prior data. And the current numbers are even more. So that's really, really you know, positive for us. And yes, the other thing I wanted to touch on, although I'm going to go into the actual protocol, how we would like some consistency, but overall, in general, a primate without complications. The usual schedule that is being encouraged is 10 visits in the entire pregnancy. I'm just bringing this up because you might read that and think that ours is a little bit over-serviced, and it is. And again, that is just for various reasons. But a lot of the data that's coming out is suggesting that for multiples, usually 7 visits are ample. If they don't have any additional needs and they're comfortable with that, and we're taking, obviously, some women are anxious that they need more visits for that reason. There are many reasons that women need more visits. And this is just to put it out there that some of the numbers that are encouraged at a national level are those. But what we do in reality is providing women-focused care. Okay. So we're going to go into all of this in detail. So the EDC, again, the national guidelines have tried to standardize this concept. You know about the Niglis rule, adding 9 months and 7 days, and you know about how, the fact that the last menstrual period, sometimes women don't remember, then they remember, then the cycle's not regular, and so, or the cycle is typically longer or shorter for particular patients. So what we've been encouraged to do is that we, first of all, if she has had an ultrasound between 6 and 13 weeks, that's the second last paragraph. If the 2 dates are less than 5 days, then use the last menstrual period. So we're no longer using 7 days, we're using 5 days. If the dates differ by more than 5 days, and this is because the ultrasound services are obviously getting more and more, there are better machines, and for various reasons, if they differ by more than 5 days, then we're to use the ultrasound estimate. Now, in general, if a patient comes to us and she says, look, I'm unsure of my last menstrual period, ideally we shouldn't be doing an ultrasound around the 6-week mark, unless she's having bleeding or she's had a previous ectopic or there's something special about her. Please try and time the ultrasound to the 8-week minimum mark, because on one hand, we obviously don't want to miss the nuchal opportunity, which is a window of opportunity, but on the other hand, we don't want to scan her too early, because then we may have to scan her again, or it may not be worthwhile. So in general, we're trying to time that, and what this book says is that to try and time it between 8 and 13.6, but obviously that's a bit optimistic because we don't want to time it at 13.6 because we want her to sort of have her nuchal. So I guess what I, in a practical sense, encourage is somewhere around the 8-week mark. And obviously if they're more than 13 weeks and the dates differ by more than 10 days, these are less likely, I think, in our our situation would be less likely to see women 20 weeks and not knowing they're pregnant, but obviously they can happen anywhere. I've been called to emergency where, you know, someone's having pain and then they've delivered and we were like, okay. And I like, well, they didn't know. So yeah, so anything can happen, but in general, I think most of us are seeing people around the 13-week mark. So what's the plan for these patients? Again, first antenatal visit is long appointment. Fiona, so in our protocol it says 1 or 2 visits. What do you do normally?
We certainly have a long visit.
Long visit?
Just because they have often come with so many questions that they get their list out, and if you haven't left more time, then they're going to be anxious leaving if they haven't answered, if you haven't answered some of their questions.
And then they'll feel that they haven't quite gotten the whole to-do list. Is
There's
that?
a lot of things they have to do. Like
Yes.
You've got to start planning those next visits when they come back and what you've got to do and who you've got to ring and
Yes.
care they want. Yes, what type of care.
Is that what almost everyone does? Yep, okay. So that's the first visit. And the first visit is encouraged before 10 weeks of pregnancy. And we want to date the pregnancy to the best of our ability. We want to calculate her BMI. We want to test her blood pressure and test for proteinuria. Again, that is to send off the midstream urine because we're checking for bacteriuria or a UTI. And of course, all those other things that we mentioned in a preconceptual context, the histories and the relevance of all of that need to be done. The interesting thing is that routine breast or pelvic examination is no longer recommended in this context. I remember, I'm probably showing my age now, of how we used to have to do thousands as residents because it was part of our initial when the patient came to the hospital. So, but that's now no longer recommended. Not the pelvic, I used to do the breast exams, that's what I'm talking about. Anyway, so then from the blood point of view, we obviously want to know whether she's negative blood group or positive, and we want to know whether she's having any antibodies. A, because they could affect potentially the fetus by passively transferring across the placenta, and B, if she has a PPH or we need to transfuse her, we need to know, we need to identify those patients that might have issues. And so a full blood count and a hemoglobin. So again, what numbers do you use for, like, for example, iron supplementation? Because iron supplementation is no longer routinely encouraged. The only two things, like you rightly said, are folic acid and iodine supplements. So iron we give for either at-risk groups or if they're anemic to start with. So we tend to encourage under 11 to check her ferritin and to try and encourage some, because that's, as a starting point, we know that the baby is going to be practically like a parasite and drain her reserve, and we also know that she's going to hemodilute, and so therefore that hemoglobin is going to drop. So we test for HIV, Hep B, because there's something we can do postnatally, and rubella, syphilis, and asymptomatic bacteriuria. I'm just interested, have any of you picked up any positive syphilis that you weren't aware had been previously treated? Yes, Caroline, have you?
I had one in a recently arrived Tibetan refugee. It was incredibly difficult to explain to her, and she had no idea
Right.
whether it was sexually transmitted
Previous.
or whether it was one of the, I learned a lot about it while I was talking to the Clinic 16 at Royal North Shore,
Yep.
whether in fact it was a
False positive, which can happen, yep.
But in fact it wasn't, it was a true positive. She didn't know
Wow.
where she got it from, and she was treated.
Okay.
And her partner also was treated.
Okay, well, that's, you know, very good to know. But what you've touched on is that a number of times it's a false positive, and we need to establish that that's not. And it can create a lot of anxiety and you know, issues while you're trying to work out what is actually going on. The other thing is that I must say, in the hospital sometimes we're guilty, and we're trying to introduce a bit better, is that women who are younger than 25 to test for chlamydia. Is everyone doing that? Consistently in pregnancy? Very good, excellent.
And why the 25 cutoff?
Look, I think that's a cost-effective thing where they've found that they're getting enough numbers to balance the amount of tests that we're having. That's my understanding, and obviously the younger girls are more likely. Yep.
Higher prevalence. It's just that we've been saying that for a while, and those 25-year-olds are now older. Now 35. I mean, we've been talking about that for a while, so the logic is kind of lost a little.
I think it's very financial. I would think targeting the higher risk group.
Why do we not have TSH?
Yes, so I was going to go into that. So again, TSH and vitamin D are two questions that I regularly get asked. Again, I think the reason why it's not routinely being tested is because the subclinical hypothyroidism, there's still not evidence that treating that is beneficial for the patient. So what they say is that if you have someone that has risk factors or has symptoms, okay, so for example, someone had previous thyroid disease or very strong family history or some sort of reason, then you screen that person, but you don't universally screen because the benefits, again, I think this is a public health analysis, and it's neither NICE guidelines, which are the UK-based guidelines, nor our national guidelines, nor the RANSCOG ones. And I've taken the liberty to request 2 of our thyroid-related guidelines and 1 article from Australian family physician that I found very helpful be linked so that you could access that later. But that's the reason why. And vitamin D, again, for high-risk women only, we recommend. And again, these are bigger picture issues. Because I often get asked, will I screen, and then I found these 3 women. But obviously, if we test, we test 100 women. We're going to find some people with the issue. But the bigger picture ethics around it is that there's a finite health dollar, and we want to spend it on where where we're most likely to maximize yield, or to change the management. And Colin's going to go into details about that. So what happens at the hospital end is that there's a notes review process, which means that when you refer to us, we then compile the results and also the midwifery initial booking visit, which is why obstetrics, yes?
Sorry, on the last slide, what's the stance on thalassemia screening?
So thalassemia, again, is either if there's a family history or if they are under 10.5 to start with. So then we would order a ferritin and a hemoglobin EPG and then take it from there. And obviously, if that tests positive, then you test a partner, you try and tactfully confirm paternity, those sort of things. So not for what we do is that we use the 10.5 and then we go into whether she tests positive or not. But if she's ethnic and she's got under 11, then I've got a lower threshold to check for hemoglobin EPG.
What I've noticed is the protocols for different hospitals in different regions have thalassemia included and others don't.
Right, because the national one doesn't have it. Yeah, no, we don't have it. And it may be reflective. We do have near chats with the wide Asian population, but no, we don't have it as a primary test in that list, unless there's reason to worry. What do you do, Colin?
And sometimes the MCV can be hyperphagic.
Oh yes, so if they're hypochromic.
If you have a low hemoglobin,
Yep.
and if you find it's microcytic,
Yep, you're more likely to worry that it might be thalassemia related. Yep.
Can I ask about the vitamin D? Is there any specific risk of vitamin D in pregnancy? And if so, is there any problem about just giving vitamin D, which is what we end up doing for most other people, because vitamin D testing seems to be so bizarre, because everyone's vitamin D deficient if you actually test them.
Look, I mean, I'm aware that they're really discouraging overdosing with any vitamin, particularly with vitamin A, I think. But again, the Mother Safe pamphlet says 1,000 units to someone that you've actually diagnosed deficient per day. But I've never considered, that's actually a very interesting question, to just routinely give it.
Pretty much do that for the postmenopausal.
But then I guess we're saying that a large proportion of women are not. So why would we give them something that, you know what I mean?
Well, it's just if you do the vitamin D testing in our current range of testing, most people that have got an inside desk job are
Yep.
vitamin D deficient according to the range.
Yep. And it's so vague when you
And
say.
you wonder whether the range is correct, because you think what proportion of the population.
time of year you're testing.
Yes, I know, it's so seasonal. And also, it's so hard to know what is someone who is indoor. It doesn't give an amount or quantify how much is, but I guess therein is the dilemma.
It were developed for people in relation to osteoporosis management and so on, so that extrapolating that into
To normal, well
or to
women.
normal, well people in any other context is
Yes,
so
it's really hard. Well, I think that's an excellent food for thought, but I really don't know the answer to that. And certainly, no, it's not recommended to obviously give it to everyone. So from a midwifery point of view, Judy, did you want to tell us about the obstetrics? I'm sure just in terms of the booking visit for when... Yes?
So it's the psychosocial screening predominantly. So we do GV screening. We ask the woman about any medical history that she may have had, any previous pregnancies. It's a very thorough 1.5-hour visit.
Yep.
Where we go through all the blood tests that she's had, send her off for any others that may be missing, and put all the notes together so that we can send them off for notes review. Ask the woman about what kind of antenatal care she would like. Whether that be shared antenatal care, midwifery practice, which is going to see a private obstetrician, which is going to come to the midwife's clinic. Sometimes that can be already ascertained by whatever risk factors that she may have, or any previous pregnancy issues that she's had. But generally speaking, we give them the options and they choose from there. So
What
all
they-
women are given all the choices, and we document on the antenatal record which choice they've made, and then that goes to notes review for approval.
I apologize. Thank you, Judy. I apologize for this. It's a very busy slide. On one hand is our contact people. So our list of, it's broken down by hospital. So there's Hornsby, North Shore, Monaville, and Manly is the same person as Judy. And again, booking in numbers. These are some key contacts. On this side is some standardization. So we've talked about the less than 10-week long visit. And Susanna, would you be kind enough to tell us about the genetic counselling in there? So the
The women who are going to be booking at Royal North Shore are entitled to be referred to general medicine for free nucleocancer scans. They'll be 35 and above at the time of birth.
Thank you.
And other women require provision.
Yep. So, and then if they need a secondary scan, if there's been a problem or there's, you know, then we refer them to North Shore in that context. So then obviously around the 11 to 13.6 is the ultrasound, which Colin's going to go into much depth about. Then we would love the patient to come back to the GP at that point and you review them with all the results. And that's a good opportunity we felt to give the influenza vaccination. Fiona, is that what you do routinely? And then at 16 weeks, they obviously go to the antenatal clinic and they have their booking visit, which is what Judy was explaining to us what they do at that end. And then, yes, sorry?
At that 14 weeks when they go to have their booking visit, they need a referral, but also all the tests that you've had done either prenatally, they don't need all of them. So if you're doing a lipid screen or if you're doing a general health check on somebody in their preconception and they've got pregnant, you're doing their antenatal bloods again, they really don't need to see all the things that really we in primary care are the main managers. Because they go through all these notes and go, well, gosh, their cholesterol is a bit high. Whose responsibility is that now to actually mention that or deal with that issue? And I truly believe it stays with us in primary care. So you're wanting to send the results that will make a difference in this pregnancy to this mother and baby and what the hospital needs to deal with at that point rather than us.
Are we still trying to do the bloods through palms so that the results are on the system?
No,
Whatever.
You live across the street from Palms.
They can go wherever they like.
Whatever they...
Yeah, but I mean,
yeah.
I
But if
prefer
they've
not
done
to.
on pounds, then it's on.
It's easier for us to
It is easier to
If
access.
you send them elsewhere, we'd really, really love it if you could put fax number or ask if they can be faxed to the hospital.
Good point,
so that we
Sue.
can get the information quickly. But that doesn't apply to North Shore because they don't want the paper trail.
So,
Physically in the clinic, so she needs to have hard copies to bring to that first visit, hard copies of any bloods and scans today for the first visit.
yes.
So can you explain the different
So the different clinic visits from, we're just going...
with the choice, so there's midwife care.
Okay, yeah. So what was really helpful for us is if you write clearly that this patient, you know, obviously she's a patient that you've discussed that option with, and she's happy to have that. So it's really helpful for us to know that that is prefers or wants or keen to explore GP shared care. When they come to us, just to make it women focused, you know, to sort of give them the options. We give everybody the same options, but we try to honor what, you know, especially if she's low risk and there isn't any other reason, medical reason to do otherwise, then to try and encourage that. But then they are still offered, look, there's midwifery, there's medical, and there is GP shared care. We try to not have anyone that's low risk in the medical clinic because they're already very oversubscribed as they are. Yep, but we do mention that those.
GP shared care, midwife care.
But midwife care is also two streams because there's a continuity of care program, MGP, and then there's a, you know, a general midwife care. So then they explore which ones they want. And then match. Yes.
Would like GP shared care, because then we will explore that. And certainly nobody is discouraged from GP shared care. We want to increase the number of women that are attending GP shared care. We really, really do.
And so midwifery continuity of care, is that when they see the same?
So there's a group of, currently, Judy, we have 6, and Susanna, and how many do you have? Yeah. Okay, so there's a cohort, it's like a, you know, like an obstetric practice with 4 or 5 people, and so they do try to see their own patients, but obviously with leave and all that, whoever covers. But then the beauty of that model also is that the midwife then goes and sees them in the home afterwards. So it is a continuum of antenatal care, intrapartum care, and postpartum care. Yep, and so to round off, then there's the ultrasound, which is meant to be timed ideally between 18 and 20 weeks. And then at 20 weeks, they come back to see yourselves after the ultrasound. And then, of course, you go through, you know, fetal movements and review the ultrasound results at that point. And then bring them back 4 weeks later at 24 weeks to yourself. And at that point, again, you're arranging for the 26 to 28 week bloods, which is the sugar, which we are currently doing GCT, except on risk patients. That's one can of worms, because ADEPS and WHO have recommended that we do GTT on everybody. We do it twice for women that have high risk, and for other low risk women, from a diabetic point of view, we do between 24 and 28 weeks. What we do in reality is that we try and offer the high-risk women an early GTT, but then for the rest of the population, we're still offering a 50-gram GCT between 24 and 28 weeks. So I'm sorry to make it very confusing, but I'm trying to put out what is standard practice and also where we deviate from that if we do. And so, yes, and then there is a 28-week visit, which is at the antenatal clinic. So the antenatal clinic visits, as you will, which is very hard to see, are at 14 weeks, are at 28 weeks, 36 weeks, and then at 40 weeks. Okay, and interspersed with that, at the GP visits are at 20, 24, 31, 34, and then 38 weeks. Okay, so the other thing that we've recently introduced is the pertussis, and that's also, I'm sorry to make it very region specific, but Susanna at North Shore, we were starting to...
We're going to move towards it being given at the 28-week visit for midwife care patients only. The GP shared care ladies, we're still encouraging to have that at the 31-week visit.
So from our point of view, we would be eternally grateful if you kindly gave the 28-week pertussis vaccine.
Everybody is going to their GP.
Anyway, yes. Okay. Sorry, Colin, I hope I haven't taken much of his time. Okay, all right. Thank you for your attention, everybody. Thank you.